Hello, everyone. I wanted to talk to you a little bit about the content in modules 4 and 5. I I think what you're going to see in the bulk of your practice, if you're doing adult care, is going to be what's in these two modules, which is bipolar disorder, depressive disorders, and anxiety. So I wanted to give you a little bit of information about just some random things I know from practice and also some stuff from the book that I wanted to point out. One thing I wanted to talk about before we talked about anything else was that when I looked at exam one, I noticed that there was a little bit of a trend that people weren't getting the questions right that had to do with diagnostic criteria. So make sure you know what's the difference between bipolar 1 and bipolar 2 and what makes somebody that comes in with bipolar disorder depressive state different than major depressive disorder. And so that's in the book, and I'll talk about it a little bit in this lecture, but it's also in the DSM. It's pretty straightforward there. But I'll be willing to answer any questions you have. Just email me or call me if you have any specific questions. So, all right, I kind of got my thoughts organized and went through the book, and so I'm going to go over some of this stuff I wanted to point out to you. Okay, let's see. The first thing I want to talk about is make sure you do a very good history. It is very important, and sometimes that takes more than one visit. We will can only make a diagnosis of bipolar disorder if somebody has had a manic or a hypomanic episode, and so make sure you assess for that, and also make sure that it is truly a manic or hypomanic episode, not just them telling you that. In Kaplan and Sadek, there's a table 6.1 on page 366, and it does a very good job of explaining the difference between unipolar and bipolar disorder. There's also, I like the table on I didn't write that on the page for you, but it's table 6.2, and it just has the criteria and of course, the criteria in the DSM as well. Over the years, I've had patients tell me things like my mom, wife, girlfriend, husband, boyfriend, whoever told me I'm bipolar. It may not be bipolar. I'm sorry, it may be bipolar they have, but that's not how we diagnose it. We usually need to know what symptoms they have. They usually tell me things like, well, 1 minute I'm fine and then I'll lose it. And that's not a good thing to do, but that's not bipolar disorder. It could be anxiety, depression, a personality disorder, but it might not be bipolar disorder. And another thing they tell me sometimes is they come in and they say, I have bipolar disorder and I have rapid cycling because my mood changes every minute. Well, that's not what bipolar is either. That's maybe some anger issues. The reason I'm harping on this is that we need to make the correct diagnosis so we can treat the symptoms appropriately. Over the years, I've seen diagnoses be discussed more than others. Like in trends, about 20 years ago, it seemed like everyone was diagnosed with bipolar, and then it was ADHD. And then we had a trend that everybody was coming in and telling me that they had DID, and now it seems like everybody's coming in and telling me they're on the autistic spectrum. So just pay attention to that. Sometimes, our social media and our things we see online kind of lead people to think those things. Sometimes people will come in with a list of all the symptoms of whatever illness they think they have because they've already looked it up, and they say that they have all the symptoms. It's unlikely that that person will come in and have every symptom on the criteria list for bipolar disorder, but listen to them and see if they have any of those symptoms and then make a correct diagnosis. I do like the fact that all that being on the internet and people being able to access that, it can sometimes identify symptoms that people wouldn't recognize as a problem. Let's see. If somebody comes in to see you and they have bipolar disorder, and they come in with depressive symptoms because they're not going to really come in when they're hypomanic or manic because they feel good, but they come in with depressive symptoms and you start them on an SSRI, one of the other antidepressants, it could lead to elevation in mood to the point of hypomania, mania. So that's why it's very important to assess for any past hypomania or mania. Lithium is still appropriate, and it's a very effective first-line treatment for bipolar disorder. It does require frequent lab monitoring the level and renal functions. So sometimes it's not the best choice if people don't have the ability to get that on a regular basis. Some of the newer meds we use are a little bit easier for patients, and we don't have to get the labs done. I have a lot of people that are on Vraylar. I can't think of anybody that I have on Vraylar that's bipolar 1, but I have a couple that are diagnosed with bipolar 2, and they seem to do well. I use Latuda. I use Seroquel sometimes if they're having trouble sleeping. If somebody comes in the hospital and they're really, really manic, elevated mood, just not doing well at all, I'm probably going to give them olanzapine to begin with because it's so sedating. Maybe a higher dose of Seroquel, but probably olanzapine. And then once they're able to calm down a little bit, I'm able to try to find some information from collateral family members or previous hospital records, or maybe once they calm down, they can tell me what's going on. I may start them on lithium at that point and stop the olanzapine. But we use a lot of the other antipsychotic medications. We talked about those in previous module 3. We use Risperdal, Abilify, Seroquel, Invega, Geodon, Saffris, and some of those can be given injectable, so that's always a bonus in some cases. There's not a exact med that's going to help everybody in the same way. We don't have that printout they give us when you send in a urine and you need to see what's going on. The lab prints you out something that tells us what antibiotic to use. We don't have that. So we have to use some educated guesses. There's a table on page 375. It's table 6-7, and it provides a real good summary. And sometimes we know what we need to use for a patient, but they don't always agree with that. I had a patient years ago who would only she was really manic. She would only start taking a medication if it started with an A because her name started with an A. I wanted to put her on something other than Abilify, but Abilify was the only one that started with an A at that time, and so I put her on Abilify. It is not great, but that's what I did, and when she got a little bit better, we were able to change it. Last week I had somebody who really needed Risperdal, but he would not take it because he saw on TV that it caused, quote, man boobs, end quote. I gave him Invega, and he was in agreement with that, and Invega and Risperdal are very, very similar when they are metabolized. I don't use a ton of Depakote for bipolar disorder because I'm seeing some younger patients, and they tend to do better on some of the other medicines, and I don't have to worry about liver issues or getting labs. I've used it in the past, and it's an appropriate medicine. I've used it in the past, and actually I increased somebody's today. It can be combined with lithium without any difficulties, but of course we have to watch the liver, and we have to watch for women in childbearing years. And so the population I'm seeing right now, I have a lot of young people, and so I'm a little leery because I don't want them to be taking that and get pregnant. It can cause some significant birth defects, so we don't want to do that. And sometimes they don't tell you when they're pregnant right away. Now in the hospital we can do a pregnancy test, but I'm talking about in the outpatient practice. For years, Depakote's been used to treat aggressive behavior. There's no evidence-based research to support that. At least the last time I looked at that, there was none to support that, but it was used all the time in that fashion. It probably helped the mood overall, which hopefully made them less angry, or made them a little sedating, so their aggressive behavior decreased. But you'll see that used sometimes still. Let me go back. There's a table 6-6 in Kaplan and Sadik, and it's got some recommended meds. Also take a look at the Carlac document I posted, I don't know what day, last week sometime, for acute mania. It has a box, I think it's on the right-hand side down the bottom, saying that Lamictal and Trileptal are not effective to treat acute mania. I agree with that. I don't have a problem with that thought, but we do use it for maintenance. And so you'll see people using it for maintenance. And we also use Tegretol with good results. Tegretol and Trilepta are very similar. I wanted to bring this to your attention. I don't have any evidence-based research to support this, but I'm just going to put it out there. About a year ago, I asked one of the docs I work with about a case. I had tried multiple medications for her anxiety and other vague symptoms without any luck. He said, she probably has a personality disorder, put her on Lamictal. So I did. That's been about a year ago. She's on a low-dose Lamictal, 50 milligrams. She's not had any adverse effects that she was having with all the other medicines. She's symptom-free. She's doing wonderful. So I don't really have any reason to support that except maybe just some mood stabilization, but she doesn't have a history of bipolar disorder. I do not think she has bipolar disorder. She basically had anxiety, but the Lamictal, the lamotrigine worked. So we use medicines for different reasons. Let me touch a little bit about depression. The official diagnosis is a major depressive disorder with or without psychotic features. So remember that people can have psychotic features with depressive disorder. In the book, it has dysthymia, but this is the same thing as persistent depressive disorder. And it is, if you think about it, it's non-recurrent. The symptoms are present for greater than 2 years is what the difference is. With major depressive disorder, you will have a remission in symptoms, and then maybe the patient comes back to you, 5 years down the road and say, my symptoms are back. I think there are lots and lots of good medicines for depression. I posted that Carlac chart to give you a good place to start. I don't think there's necessarily one better than the other. You've just got to figure out what works for that patient you're seeing. On page 389 in Kaplan and Sadek, there is a table that I like. It's 7-11, and it's got a summary of meds and possible adverse effects for you to educate patients on. If somebody comes in and they're reporting depressive symptoms and maybe some anxiety, I usually start at SSRI, know the side effects, and use those to your advantage. If someone's underweight, really anxious with a possible PTSD, I'm going to start Paxil or Zoloft. Paxil if they're underweight, because Paxil usually causes weight gain. Zoloft if they're concerned about their weight. I use them on a regular basis. Paxil and Zoloft have been proven to be beneficial with PTSD treatment. If somebody comes in and tells me they don't have any motivation to get out of bed, they're just, don't want to go to work, don't want to go to school, whatever it may be, I usually start them on Prozac. It's somewhat stimulating. I give it in the mornings. If they tell me they have a little bit more anxiety, I use Lexapro. Lexapro and Celexa are very similar. People tend to tolerate Lexapro a little bit better. You've got to watch the prolonged QT with all these medicines. They all have the same side effect profile. People mainly complain of headache and nausea for the first couple of days, but it should subside. If it doesn't subside, I usually switch them to something else. Another issue, and I've only heard it happening with Prozac, there's a rash that can occur. It's not a Steven Johnson or anything like that. It's just a rash, but it doesn't occur right away. It can take up to a month to occur, and so sometimes people won't associate it with the Prozac. If somebody comes in and they failed on SSRIs, you need to ask them, spend some time and talk to them about, okay, how long did you take it for? What was the dose? That kind of thing. Because what happens is a lot of times people will go to their primary care provider and they'll start an SSRI and they'll call back the next week and say, this 25 milligrams of Zoloft is not working, and they'll switch to something else. And then they'll switch to something else the next 2 weeks. And so the primary care provider is trying to get the patient to feel better, and the patient keeps calling and saying it's not working, and so they want to get them to feel better. But that's not an adequate dose in an adequate amount of time. You got to give it about a month, and it's got to be at an adequate dose. So what they do is they come in and they tell you, I failed on Paxil, Zoloft, Lexapro, and Celexa, and they never had an adequate dose or time frame. So I bumped, if somebody comes in on Zoloft, 100 milligrams, I've gone all the way up to 300 milligrams on Zoloft. Celexa, I try to keep under 40 and under, because we used to bump it up to 60. and they came out with some reasons why we shouldn't, so we try to keep it under 40. Paxil, I've gone up as high as 80, I think. Prozac 80. Lexapro, usually 20 is my norm, sometimes 30, depending on if the patient's tolerating. You can also do a gene testing to see how patients are metabolizing medications. If they are on high doses and they're not having side effects, you can bump it up. But you can get that gene testing to see if they're metabolizing it quickly, and you might need to increase the dose. And if they're not metabolizing it well, they're going to come in with more side effects. All right, so after you decided, okay, SSRIs are just not working, or they have side effects, or whatever may be the case, then I would switch over to SNRI, and those are the medicines like Effexor, Prestige, Cymbalta. The only time I would probably go to Cymbalta first line for somebody is when they come in with depression, anxiety, and pain. Remember that Cymbalta has an indication for neuropathy and for musculoskeletal pain, and so a lot of our patients have ongoing pain too. Remember that Savella is very similar to Cymbalta. It's in the same class. It's an SNRI, and it does not have an indication for depression and anxiety, but it's often given it's got an indication for fibromyalgia, so it's often given for pain. So make sure if somebody comes in on that you're not loading them up on another SNRI, because you don't want to do that. People tend to tolerate Prestige a little bit better than Effexor. Effexor comes in a tablet, and it also comes in an extended release. They tolerate the extended release better. But if you've got somebody on 300 milligrams of Effexor, and if you can, I would decrease that slowly and get them off of that high dose. They're not going to have life-threatening withdrawals or anything like that, but they usually tell me they feel like they have the flu. And if you're titrating a new medicine, say you're transitioning them from Effexor to Wellbutrin, and you trying to decrease that Effexor, and you do it too fast, and you start the Wellbutrin at the same time, they're going to say it's from the Wellbutrin causing the side effects because they've been on Effexor for a long time and they have never had those side effects. So just be careful with that. And usually if I have time and they're not having any major problems with it, I'll decrease by 37.5 milligrams every 3 or 4 days. And they seem to do well with that until you get them off of it. Remember that high doses of Cymbalta and Effexor and Prestige, sometimes the high doses can increase the blood pressure sometimes, so you got to be careful with that. People also tell me that they have what they describe as brain zaps when they decrease or stop the Cymbalta abruptly. I'm not sure exactly what's happening in people's brains, but lots and lots of people tell me that all the time. It doesn't seem to be harmful in any way. I can't find any documentation, excuse me, to explain that 100%, but for all patients, but it usually goes away once they've been off of it a little while. I rarely use MAOIs, mainly because of the interactions with other medications and the dietary restrictions. I do see one patient who's on Nordial, and she says it's the only thing that helps her. They are difficult to find sometimes because they're not used very often. I have used TCAs like amitriptyline and doxepin, anafranil, just a few of those I'm thinking off the top of my head. They work. They work very well, but their side effect profile is not great. They usually cause significant dry mouth, constipation, weight gain, sedation. And so people are kind of sluggish and not feeling great when they're on them. As far as the side effect profile, they can also be fatal if they use an overdose. So I get a little anxious about using those with people who have overdosed in the past or have suicidal ideation. GI and pain management docs use some of these for GI distress and sleep and pain. So you'll see that being used in low doses like amitriptyline, like 10 milligrams. Doxepin, the name brand of that is Sinequan, that you don't see very often. The lowest it comes is a 10 milligram tablet, but there was a sleep medicine that came out, Silenor, which is actually Sinequan or Doxepin, but it comes in a 3 and a 6. but it's the same exact medicine. Now, insurances they don't want to pay for Silenor, so if somebody really wants to be on that, I'll order the low dose doxepin, which is 10 milligrams. It's in a capsule the last time I checked, so you can't break them in half. But they usually do pretty good on that. Speaking of that, sleep, trazodone is an antidepressant. It's not just for sleep. We used to use it all the time for depression, and it's very effective. It's kind of in a class out there on its own. It's very effective. But of course, people were taking it multiple times a day, and they were sleeping all the time. So that's not good. But we use it all the time now for sleep, or you can use it for adjunct therapy for depressive symptoms as well. All right, let's see. I like mirtazapine. Remeron is the name brand. I like that for the patient who comes in. They're depressed, they're anxious, not sleeping well, not eating well, and maybe sometimes even if they have some nausea, it'll help a little bit. It can cause significant weight gain, and so you don't want to use it on somebody who's already struggling to lose weight. But somebody that is not eating and not able to keep weight on, then it's an excellent choice. We use it a lot in the older population, and they seem to do very well on it. Two other ones that I don't use tons of, but are good, Vibrant and Trintellix. Those two are not supposed to have any sexual dysfunction. The other ones all do. But both of these have significant adverse effects. Vibrant seems to subside after you've been on a week or so, but some patients tell me on Trintellix, which I love if it works for them and they don't have side effects, that the nausea never goes away. I had a young man that came in, I don't know, maybe a year ago, and he was saying that he was feeling good. His mood was good, no anxiety. I use it a lot for anxiety. No anxiety, but he was still vomiting every day and taking Zofran every day. I'm like, what? I was like, no, that can't happen. So I got him off of it. But he had never told me that before. But typically it goes away, but not for everybody. So if you put somebody on it, make sure the GI distress goes away. I think the Trintellix is, I don't know how I can remember random stuff like this, like 23%, which is pretty high for a trial for GI distress. I'm sorry, somebody was calling me. I got distracted. Wellbutrin. I like Wellbutrin. It is a good medicine. It is not a stimulant medication, but it is a stimulating type medication. If somebody comes in and they're depressed, hadn't gotten out of bed, they don't want to do anything, they're just no interaction, can't find the energy to do anything, I think it's a good medicine for them. In the higher doses, it can increase the blood pressure and it can increase some anxiety in some patients, so you kind of got to monitor that. That's usually over 300 milligrams. I have had people as high as 450 milligrams, but that's really not the norm. About the highest I go is 300. I did have somebody come in not too long ago into the hospital, and they were on 600 milligrams, and they were super anxious, and I stopped that right away. Be careful what you're looking at. Avalti is the newest one. It is a combination medication that has Wellbutrin in it. So does Contrave. Contrave is the weight loss medicine. I don't know if you know about that, but it's the weight loss medicine. It has naltrexone and Wellbutrin in it. So if somebody comes in and they're on Contrave, it's not that you can't give them Wellbutrin. You just need to maybe adjust the dose. And remember that Zyban, I don't know if y'all remember Zyban, it's not name brand anymore, but it was marketed to help people stop smoking, and it worked, but it's just Wellbutrin. It's the exact same medicine. Let's see. I really didn't talk a lot today in this lecture or in the class so much about depression during pregnancy and postpartum. It's not that I'm ignoring that. You'll review that in another course, but I certainly did not want to acknowledge that. It is a very real problem for some people, and it needs to be treated. It needs to be assessed. Years ago, we did ECT on a lady. I'll never forget. It's probably 25 years ago, 30 years ago. We did ECT on a lady in the clinic during her pregnancy because she didn't want to take any of the medications that could be harmful, and she did very well with that. And we did ECT monthly after that so she could breastfeed. Some of the medicines now, the OBG OBGYN docs use, they use a lot of Zoloft. They've used Wellbutrin. They've used some of the other ones, other SSRIs. So what I usually do if somebody comes in and they're pregnant, I just usually coordinate that with the OBGYN and see what they want to do. But you will have that information in another class, so I didn't want to ignore that. All right, let's talk about anxiety because y'all probably tired of me rambling about random stuff. When we talk about anxiety, I'm talking about generalized anxiety disorder, panic disorder, social anxiety disorder, and the phobias. Know the difference between all of these because you're going to want to know the difference to be able to treat it appropriately. They all share symptoms, but there are some distinct differences. Benzodiazepines are no longer first-line treatment for generalized anxiety. SSRIs are. I do use benzos short term, and I think other people do too. Especially if somebody comes in really anxious and we know that SSRI is not going to work for a few weeks, and so we can use benzodiazepines temporarily until they start working. I take the time to educate patients on that and make sure they understand that it is not a long-term medication, it's short-term, and then I can use it, PRN, or they can use it. I don't use it. I can prescribe it, PRN in the future if need be. Oftentimes, what I see in practice is the primary care provider will prescribe an Ativan or a Xanax, and then they'll refer them to psychiatry, which is appropriate. It gets rid of that acute anxiety, and then they refer. The patient comes in and they'll say, "Oh, I'm fine. I'm taking this Xanax 2 milligrams 4 times a day, and I'm good. I don't really think that I need to change anything." And I'm like, "Oh, yes, we do." I have had patients come to me on 8 milligrams of Xanax, 8 milligrams of Ativan, 8 milligrams of Klonopin over the years. And so it takes a while to get them off of that because, number one, it's a high dose. Number two, they don't feel anxious anymore, and they'll do anything not to feel like that. And so I understand that, but that's not a good long-term plan. I do have a handful of patients who've been taking benzodiazepines for a long term. When I say long term, like greater than 20 years, and I'm still trying to get them to decrease it. We've done some, but not 100%. Sometimes as people age, I can talk to them about, risk for falls, risk for increased confusion. It doesn't cause dementia, but increased risk for confusion just for not metabolizing things, including benzodiazepines, as well as we used to when we were younger. Sometimes they need to stop it for medical reasons, or maybe they've started another medicine that interferes with. So hopefully I will continue to try to get some people off of them and treat them appropriately. But just don't, I gave a discussion, I had a discussion, a lecture in a counseling class today, and we talked about this a little bit. Just don't tell them, "I'm going to take you off the benzodiazepines." Make sure you explain to them that, yes, I'm going to take you off of this, but I'm going to give you something that's going to help you, and it's going to prevent you from having those panic attacks, prevent you from getting into the state you were in when you sought treatment to begin with. And sometimes that takes multiple visits. We give propranolol for some patients for anxiety, and it works. I use hydroxyzine, and patients report positive effects from that. Lately, this has been going on. A friend of mine, who's another nurse practitioner, called me about 6 months ago and asked me if I was seeing this. There's been a trend of the last couple of years for providers telling people to take Buspar PRN. It doesn't work like that. You have to take it daily for several weeks for it to work. It can cause some sedation in some patients, so maybe that's what they're getting, how they're getting relief from their anxiety. Maybe they're sedated and it's relieving their anxiety. It's not going to hurt them to take it PRN, but it's not going to work great like that. I went to a conference last year, and it was nothing but psychiatrists, and somebody brought that up. There was probably about 120, 150 psychiatrists in the room, and all of them were like, "No, you shouldn't take a PRN. It's not necessarily going to work like that." This was just a blurb I want to put in there. There's a table on page 410. It's table 8-8. It looked at how we compare U.S. and when I say we, how the U.S. compares to other countries. It was just interesting to look at some of that stuff that some of them are doing a lot better than we are when it comes to mental health. And I wonder why. Is it not diagnosed? Is it not reported as much? Is it that they're not suffering as much? I don't know. It was just interesting to look at. That's not going to be on the or you need to know in life, but just, I don't know, thought it was interesting. Um, okay. When we're looking at depression, bipolar disorder, anxiety, remember that therapy works. Encourage them to get into some therapy. You will be licensed as nurse practitioners to bill for therapy, but you're probably going to need a little bit more education than we have here in these classes if you want to get really good at it. But because you will run into some difficult cases and you want to be prepared for that. If somebody comes in and is super anxious or really, really depressed, I try to get them to feel a little bit better before I refer them to therapy. But I usually refer everybody to therapy, especially with some anxiety. They benefit from it tremendously. Remember, we have group therapy as well as individual therapy for our patients. So don't forget about the IOPs. And that's a good resource for patients that are really depressed, especially if the IOP provides transportation. It'll be somebody coming to their house. Here in Baton Rouge, we do it about 3 times a week. So coming to their house, knocking on their door, saying, hey, get up, and hopefully we'll encourage them to get out of bed and be interactive and be around other people. That in itself can make you feel better. A little bit about hospitalization. Typically, we hospitalize for, of course, suicidal and homicidal ideation, as well as mania and psychosis. Another reason I see that we hospitalize sometimes for is for medical instability. So if somebody is really severely depressed and they're not eating or caring for themselves, so that may be a reason to hospitalize them even if they're not suicidal. Most of the hospitalizations now are very short term, but it will maybe get them started on some medication and make sure they're medically stable. I've seen people get hospitalized for severe anxiety just because they can't function. They can't make a decision. They can't take their medicine. They're scared to take medicine, things like that. So I'll see them hospitalized for severe anxiety. And also, if they've got a good support system at home, you might not need to do that, but everybody doesn't have that. Of course, pay attention to if the patient's using any illicit drugs or alcohol, because that's going to, of course, mimic some of these symptoms we've talked about in depression and anxiety. So make sure you always assess for that and see what's going on. Also, any medical conditions, and we've talked about that in other discussions, and I've talked about that in some of the other PowerPoints and things like that. Pay attention to that, especially, our thyroid. We need to make sure that's within the right range. That can look like anxiety or depression or even mania, hypomania too. Okay, the rest of this, I'm going to hopefully not be as long-winded as I've been so far. I wanted to just touch on a few things about the other topics in this module, OCD. Remember that obsessive compulsive disorder, remember that the obsessions are the intrusive thoughts and the compulsion is the act of doing something. So the compulsion seems to reduce that anxiety that the obsessions cause. So people will have rituals sometimes or things they have to do to be able to go forward. The most common obsession is somebody thinking something is contaminated, whether it be that their hands need to be washed all the time, their food's contaminated. So that they're concerned about germs and things like that. And that's why they're always cleaning or washing their hands or wearing a glove or whatever it may be for them. Then they, the next most common one is doubt. Like they feel like they forgot something or they need to check something all the time. And then people, after that, the third one is like forbidden thoughts. Like they have these intrusive thoughts that they have that sometimes is sexual, that they've done something, or aggressive, they've done something like that. So remember that these thoughts, and I'm sorry, the last one is they need to have things, the fourth one, most common, is that they have to have things in order. Like symmetry, you'll see people place things on a table in the same exact way, and it stresses them if it's not in that way. But remember, all these symptoms or these thoughts or actions have to be to the level where they interfere with the day-to-day functioning. We also have some other disorders in this group: the hoarding, the skin picking, the pulling of the hair, the body dysmorphic disorder. So the therapy is very, very important in these disorders. We do use SSRIs. Luvox has an indication for OCD, and there's a TCA, anafranil, which also has a indication for OCD and has been used for years. When we and the other SSRIs should work as well, in theory, but sometimes we have to use much higher dosages for some of these symptoms to be resolved or have remission of these symptoms. And some of the, like OCD, PTSD, all this kind of stuff used to all be under the anxiety umbrella, and now DSM has separated them out. So PTSD, acute stress disorder, and adjustment disorder. Remember with this, you have to look at that time frame. So PTSD can't be diagnosed until the whatever event happened is greater than a month from when the patient has symptoms. So if something happens and the patient has some acute, response, and it's within 3 days to a month, you would diagnose it with acute stress disorder. But if the symptoms are still present for a month after the event, then you would say the patient has PTSD. Now, it sometimes is very clear that when somebody has an event and they come in and see you and you diagnose them with acute stress disorder, it is very clear that they're most likely going to have PTSD. That's maybe true, but in the very beginning, it doesn't need to be diagnosed. So I have a lot of patients coming in now and telling me they have, quote, complex PTSD. That's a term that I'm hearing lots and lots of patients say, more so than any clinicians. But therapy is, look at, before I go on to anything else, look at tables 10.1, 10.2, and 10.3 in Kaplan and Sadik, and they will give you a good explanation of the differences between these three disorders. Therapy is very important for these patients. I think it's a must. Paxil and Zoloft is shown to be most beneficial to treat PTSD. There is no evidence to show that benzodiazepines are effective. The other things we have in this area is somatic symptom disorder, conversion disorder, dissociative disorder, factitious disorder. If you're doing hospital, conversion disorder is also called functional neurological symptom disorder. If you're doing hospital consults, you'll probably see this. They usually call us when they cannot find a medical reason to explain patients' presentation. And so it's very difficult to determine that in the hospital, but there is a physical exam questionnaire. It's on, I didn't put the page down on my notes, I'm sorry, but it's on, in the book at 12, the table's 12/5. So you can look at that if that's something you're going to be doing on a regular basis. Some of these things in that questionnaire are already completed before they even call us. Dissociative disorder is very rare. There's also a good table, 11.13 in Kaplan and Sadik, and a mental status exam on page 443 that is a good resource if you think somebody has DID. Factitious, that is basically the person is just telling you they have an illness that they do not. People are very good. They are very convincing, and they do this maybe for different reasons. There's another good review of that in the book on it's table 12.8. So that is a lot of information. Some of it is stuff from my practice. Some of it, like I said, is stuff you need to know so you can have a good practice. Some of it is some basic general information. As far as the test goes, I'm not going to ask any super detailed questions because it's a lot of information over these two modules. The bulk of the test questions will come from bipolar disorder, depressive disorders, and anxiety disorders, because I think that's what we see the most in children and adolescents and adults. Don't stress about learning every detail of everything in this book. Remember that you'll have repeated this information in 691, 692, 693, or if you're a postmaster student, 697. This course is an introduction to it, and I know that, so I'm not going to ask super detailed questions. I will go over the test again, and if I see that I've asked something that maybe I didn't talk about, or it's not on those PowerPoints or pretty clear, then I'll give y'all another announcement or something about that. But I think that y'all will do fine on this test. I think it's easier than the first one, so that'll be a good thing. But don't let that fool you and not study for it, because it is a lot of information. As usual, please call me or email me if you have any questions about the material or anything I can do to help you. All right, y'all have a good night.